Welcome to the fourth speaker in our 2020 Innovation Business and Law Center Speaker Series. I'm Jason Rantanen, a professor of law at the University of Iowa College of Law and director of the Iowa Innovation Business and Law Center. Today, I'm delighted to welcome Professor Rachel Sachs of the Washington University in St. Louis, who will be talking about reimbursement policy and responses to COVID-19. As a reminder, today's program is being recorded. After Professor Sachs speaks, we'll have some time for questions, and you can type those questions using the question function in the Zoom webinar. With that, I'm delighted to introduce today's speaker. Professor Sachs is a scholar of intellectual property and health law at Washington University in St. Louis. Professor Sachs' work explores the intersection between intellectual property law, food and drug regulation, and health law, as well as the challenges posed to accessing new innovations in the health technology space. Professor Sachs' scholarship has appeared in places such as the Harvard Law Review, Michigan Law Review, NYU Law Review, Minnesota Law Review, Journal of the American Medical Association, and New England Journal of Medicine. And with that, I'm thrilled to turn this program over to her.
So as Jason mentioned, for those of you who may not be familiar with my work, I really do focus on this interaction between different areas of law that affects both innovation in and access to new healthcare technologies, patent law, food and drug regulation, health law. And I've written quite a bit about the role of reimbursement policy in driving innovation incentives for new healthcare technologies. And in this presentation, I'm first going to explain the relationship between reimbursement policy and innovation incentives, and then explain how COVID-19 has really revealed both the possibilities and the challenges of this idea. So just a brief note before we get started, for those of you who've attended some of these other great webinars over the last few weeks, you may have seen talks by Nicholson Price and Jake Shirkow, and next week, Lisa Larimore-Wellett will also be participating. The four of us have been co-authoring a series of blog posts on Lisa's great written description blog, where we apply many of the insights of this field to particular policies in the COVID-19 space. So I urge you to check that out if you're interested in this topic. And two other articles that you might be interested in if you find interesting this idea of reimbursement policy as related to innovation incentives are a piece I recently co-wrote with both Lisa and Mark Lemley about Medicare as an innovation subsidy, and a piece I wrote a few years ago laying out this idea called pricing insurance, about the ways in which insurance functions like a prize, which we had often discussed in the innovation literature, but we had not discussed the ways in which health insurance and reimbursement itself functions that way. So in the interest of time, and to be a little bit simplistic about things, this is a highly simplified schematic of how I sometimes think about incentives for drug development. So if you are trying to bring a new drug, but really any healthcare technology to market, we need you to invest a lot of money on the front end. Research, development, maybe approval, regulatory restrictions, and bring the product to market, and then you can earn a return on that investment. And if it's a drug, at some later time, maybe generic drugs will enter and we bring down the prices. And if you're a company, you're trying to minimize your investments, maximize your returns. And we typically think about patents as key to this process. This is a classic story we tell where patents give innovators some period of exclusivity to recoup their often substantial investment into new pharmaceutical technologies. But sometimes there's a problem. So in different fields in the pharmaceutical space, there are often needs for investing, I'll say, a much larger amount than normal on the front end to bring a product to market. So maybe the science is particularly difficult. Alzheimer's disease might be one example here. Maybe the clinical trial process for a particular product is unusually long. Maybe you're trying to prevent a condition rather than treat it. And there's a large literature discussing the range of ex-ante incentives or push mechanisms. These are things like public financing of clinical trials, grants, R&D tax credits. Nicholson Price's workshop a couple of weeks ago focused on this question. And more generally, these are investments that pay for inputs and reduce the cost of R&D, de-risking that process. But then sometimes the problem is on the other end. So if companies know or can see that there's an insufficient paying market for a product, they're often reticent to move forward through the development process. So we often talk about patents as one form of an ex post or a pull mechanism to encourage companies to develop new products, but there are others. So you might think about something like an advanced market commitment, where a foundation or government commits to purchase a specified quantity of a particular product if it's developed, or something like a prize, where a government will offer a payout for the development of a new product. These can be effective in encouraging companies to move forward. And prescription drug reimbursement functions in just this way, to create or alter markets for a given pharmaceutical product or other healthcare technology. If you're an insurer and you decide to create or increase reimbursement for a class of healthcare technologies, then you're in doing so expanding the market for them. Pharmaceutical companies, just to single out those entities, who know that insurers must pay for their products, as is often legally required through Medicare and Medicaid, they know that they can rely on a certain level of rewards, and so they may redirect their innovative activities accordingly. And so there are a number of empirical examples in which this has been studied. Just one example is Medicare Part D is probably the clearest example in the health insurance context. So although the broader Medicare program has existed since 1965, Medicare really didn't cover prescription drugs until 2006, when Medicare Part D went into effect. And Part D provided a standard pharmacy benefit to Medicare enrollees. And as a result, it both expanded the population of seniors who previously did not have prescription drug coverage, and it increased the prices that pharmaceutical companies could expect to get for many drugs which had been sold to senior citizens who previously were only eligible for Medicaid. And the passage of Medicare Part D has been empirically associated with increased pharmaceutical investment in drug classes with higher consumption among the Medicare population. Part D isn't the only example of this, although it's a particularly big one. Professor Amy Finkelstein has discovered that several policies designed to increase the uptake of vaccines, such as Medicare's 1993 decision to cover the flu vaccine, resulted in an increase in clinical trials in those spaces as well. So I make two claims sort of in my research. One is that reimbursement in fact functions this way. Right now, today, prescription drug reimbursement encourages pharmaceutical companies to invest more in some areas than in others. But second, we can change our reimbursement policies in a way that encourages other or new forms of innovation to the extent we would like to do so as a policy judgment. And this brings me to COVID-19 and reimbursement policy. So there are a range of ways in which healthcare technologies are key to slowing the spread of COVID-19, helping patients who become ill from the disease, and moving us past this as a society. So I'm going to focus briefly on just three areas: diagnostic tests, including not just tests for those who are currently infected, but also antibody tests to determine whether someone maybe has been infected. Therapeutics, you can think here about drugs which exist but may be repurposed. You could think of something like hydroxychloroquine. And I put remdesivir in here, but it's sort of in between. It had already existed but was being tested for COVID-19 versus new drugs entirely. And then vaccines. Now, this list could be even longer. So one thing we've discussed in our series of blog posts so far is PPE, personal protective equipment. And we've talked about the role of reimbursement policy and innovation policy in ensuring an adequate supply of those products. But in the interest of time, I'll focus on these three areas and briefly explain for each one how it's related to this question of reimbursement policy. And to put it most crudely, I think the point is that we get what we pay for. If we pay for good, high quality diagnostics, therapeutics, vaccines, and if we can signal that publicly, researchers will be more motivated to create those products than otherwise. If we can't, we might be worried about whether we'll get innovation in this area, even where it would have high social value. So in some of our blog posts, we've talked about this concern that there isn't enough diagnostic testing capacity, in particular in the United States. It was true very early on in the pandemic, and it seems to be true again, unfortunately. And we have this goal, right? This goal is to develop sufficient diagnostic testing capacity to identify quickly and accurately whether someone currently has the virus causing COVID-19. And we're a little bit worried, maybe, about the way in which innovation policy is implicated here, because as those who may teach in this field know, there is a real doctrinal limitation on your ability to get patents on diagnostic tests after the Prometheus case. And so incentives may be limited, traditional incentives may be limited in that way. And so one potential solution that we've articulated is that CMS, the Centers for Medicare and Medicaid Services, should announce that it will pay enough per test to encourage companies to really scale up their testing and to ensure that there's enough increase in the supply chain for all of the different kinds of things that go into a test to enable us to use testing in a way that will help us. Because the importance of testing is, of course, not only returning a diagnosis to an individual patient, but in doing so quickly so that that patient can isolate, can avoid infecting others if they are infected. We want to be sure that we can identify hotspots as they're emerging and respond to them rather than being delayed for several days or weeks. Testing being, of course, particularly important in some contexts like nursing homes. We've seen outbreaks in prisons, meatpacking plants, etc. Those are places where it would be especially important to have this. Now, I do want to note here that CMS did do this, right? Eventually, this is April 15th, CMS announced that they would increase their Medicare payment to $100 for high production coronavirus lab tests. Today, it's not clear that we have enough supply, unfortunately, and we really do need renewed efforts to increase supply in the US. So another issue we might have is in the therapeutic space. So the goal here is not just to develop new drugs, but it's specifically to produce information that particular therapies are safe and effective for the treatment of COVID-19. So that's what we want to do. We need to know with some level of certainty what products can help us treat sick patients. And so a concern that I have here, this is one that I think has been less present in the literature, so because it's more specific to COVID-19 than it is to some other conditions that we've talked about in our scholarship over the years, so I'll bring it up now. This concern is that inpatient reimbursement policy may discourage physicians or hospitals from using expensive medicines, therefore discouraging innovation. And I'll explain what I mean by that. So this is specifically an issue that has arisen in the context of remdesivir, and I'll just note that it's been written about by the Kaiser Family Foundation. So this is the title of a recent piece that they've written, How Could the Price of Remdesivir Impact Medicare Spending for COVID-19 Patients? If you're interested in this, I would go take a look. Remdesivir has now received an emergency use authorization from the Food and Drug Administration, but is coming to market at a price of just over $3,000. And remdesivir has been restricted by the terms of the EUA, which is not the same as a full FDA approval, to use in the inpatient setting. And to date, most of the patients that have been hospitalized with severe COVID-19 have been seniors. And so most of the reimbursement that's existed so far has been through the Medicare program. So here's the concern. If you are a Medicare beneficiary and you are sick enough to be hospitalized, Medicare pays hospitals a flat rate for a patient based on their diagnosis. And so for hospitalized Medicare beneficiaries who are COVID-19 patients who don't have any other complications or comorbidities, Medicare is going to reimburse a relatively small amount, on average about $8,000 under the existing inpatient code for respiratory infections. And there are good reasons to have this inpatient payment program. So Medicare is trying to encourage cost-effective care. But if you add in this new drug, which costs $3,000 per course, that's a very large fraction of the amount that the hospital would receive to treat the patient over their entire hospital stay. And so we might be concerned about the hospital's ability to absorb the cost of that drug within the amount they're going to receive for treating the patient entirely, unless it produces really large offsetting savings, which there are some suggested in the early clinical trial evidence, but it's not clear that they're as large as would be needed. So the concern that we would have is that doctors would be reticent to prescribe this drug for their hospitalized patients because they don't think it will help the patient enough to enable the hospital to not lose money every time they hospitalize a COVID patient. This is an innovation problem in my view. So if pharmaceutical companies know that clinicians have financial disincentives to administer their products, they might be worried about the resulting market for them. And so in my view, federal policymakers should address these financial incentives. And so I think there are existing policy tools like CMS's existing new technology add-on payment program that would allow the agency to provide a bump up for hospitals who want to use these new medications to make sure that patients are getting what we now believe to be the emerging standard of care. The last issue I want to talk about briefly is vaccine development. So obviously we have this very clear goal, not just in our country, but the world, to develop an effective vaccine against COVID-19 and also to do it quickly, but to develop the information we need about its safety and efficacy as well. But a concern right here is that vaccine development is expensive, it's lengthy, it's risky, and then also that it requires customized manufacturing facilities, which usually take many years to build. And so what we may want to do is build these factories today for promising candidates, but recognizing that many of them may need to be abandoned if clinical trials for those products in question fail. We want companies to make these facilities at risk and to not worry quite so much about the potential loss later on. And so one option is direct reimbursement. So we've seen the federal government devote a large amount of money to particular vaccine companies who, for the purpose of doing this, and that's certainly one thing we could do. Another is, though, to think about ways in which we are committing to purchase the resulting product and to do so in a way that encourages companies to produce quickly and to invest in this manufacturing capacity. So we've seen a number of pieces in many different outlets making arguments about ways in which we can adopt innovative financing models for companies. So one example would be this article this opinion piece in the New York Times. One of these authors, Michael Kramer, Nobel laureate Michael Kramer, was one of the creators of the advanced market commitment for a pneumococcal vaccine, which I mentioned a few minutes ago. My co-author, Lisa Wellett, with Daniel Hamill, wrote a piece for Time magazine arguing that a classic prize system would help us accomplish the same goal. But we have a system today that would help us do it, and that's the reimbursement system. We don't have to construct a new AMC or a price fund from scratch. Having the government come out today and commit to a substantial reimbursement rate, but also one that's affordable for us as a society, that could provide additional motivation to companies in this area. So with that, I look forward to your questions, and I will let Jason keep the cue.
Terrific, thanks. So I've got some questions in mind already for myself, just from listening to your talk. But if others would like to ask questions, you can type them into the questions function in the webinar, or you can type them into chat, and we'll see them that way. So I've just got a couple questions to start out with, one of which is the government doing this? So is the government engaging in any type of advanced procurement policy or other mechanism to get companies to start building these factories with the recognition that they may just be abandoned?
Yes, so the government is doing some of this right now. So there's been media coverage of the ways in which the government has directed specific pots of money to specific companies. So we've seen announcements of AstraZeneca and Moderna and Novavax, as to name a few, receiving large amounts in the hundreds of millions or even low billions of dollars from the federal government to scale up their manufacturing capabilities early. This is before they've even entered phase 3 trials. And that's really good. So it's really important that the government is investing today in trying to develop this technology. This is not normal. So we usually do not see the government doing this. We don't usually see companies building at risk in this way. And there's a reason for that, of course, but the circumstances of the pandemic have given the government, I would say, not only reason to make these investments, but reason to make these investments while publicly admitting that they recognize that some of them will fail. And it's been interesting to see this acknowledged, not just by actors within the more scientific parts of the government, NIH, BARDA, but also within Congress, to see members of Congress say, look, we understand that this is important and that some of this money will be, in some sense, wasted because it won't pan out, but we think on balance this is a good thing. So we don't normally see that, but it's a good thing that the government is taking advantage of the novelty of this situation.
Okay, I have a question here from Bob Cook-Deegan. Rachel, how are you thinking about the research aspects of prudent purchasing for the $1.3 trillion that the federal government spends on healthcare and health goods and services each year? NIH doesn't really do that. AHRQ has been hobbled. BARDA doesn't seem to have been very good at building structures that helped with the crisis the agency was created to address. So what should we do?
Yeah, so Bob is getting at a number of very important issues here. And so I'll pick out one maybe in my response, and then Bob, feel free to follow up and ask another. But one thing that you're really getting at is this problem of coordination within the federal government, sort of within different agencies. So we have NIH, we have AHRQ, we have BARDA, all of which are sort of involved in the research area. But then we have CMS, we have the VA, we have other parts of the government involved in the purchasing area because they're insurers. And so that's what they do. They pay for goods and services, but they don't really work together. They don't really work together to think about what are the kinds of things CMS might want to call into being, things that NIH or BARDA or AHRQ can help fund. NIH doesn't really work with CMS to figure out reimbursement. So one thing you might imagine is that if the federal government is investing a very large amount of money in not just de-risking the manufacturing build out for these companies, but also in the basic research or the applied clinical trials research for these products, that we should also get a good deal on the products that result, that maybe we should get a lower price than other countries because we've already spent billions of dollars on this, or at least we should not pay more than other countries, as we've been asked to do for remdesivir. The US pays about a third more than other developed countries, about $3,100 versus about $2,300. And the problem is, or one problem is that NIH is not working with CMS to do this. So NIH or BARDA is investing this money on the front end, and CMS has to pay on the back end. And so I've written before about the ways in which HHS, the Department of Health and Human Services, which is the parent agency for both NIH and CMS, should really think about trying to address this interagency collaboration deficit and think about uniting them a little bit more collaboratively in helping us work through some of these problems.
Okay, Bob did indeed follow up. He says VA buys for many agencies and Medicaid has formal rules about covering FDA-approved goods. Could those and your Medicare subsidy be used as tools to make the system more efficient and fair?
Yeah, so this is absolutely right. So one interesting thing about Medicaid is that by law, state Medicaid programs are required to cover essentially all FDA approved drugs. In exchange, they get preferred pricing benefits. So Medicaid programs get to pay less roughly than private payers. There's a statutory discount and states are empowered to negotiate additional discounts off of that. And I've argued both that the fact that Medicaid is required to pay for drugs is itself an innovation subsidy, but also the fact that Medicaid pays less than private payers or Medicare means that if there's a condition where the primary patient population for that disease is on Medicaid disproportionately, we might be worried because a pharmaceutical company looking at the same size patient population on private insurance or Medicare versus Medicaid knows that they can get more money where the patients are privately insured or on Medicare than on Medicaid because of the size of the statutory discount. And so one concern that I have in the past is about looking for conditions where we might be worried that there isn't a good pharmaceutical intervention, and that part of the reason might be because the patients are primarily Medicaid beneficiaries, and thinking about adjusting that statutory discount in specific cases to try to encourage companies to enter that space where they might not otherwise have the incentive to do so.
I have another question, which is this a situation in which the government is just too slow to respond? That the government isn't really well set up to make the kind of responses that you're talking about for that second area of treatment? It just can't move fast enough.
So the government actually does have a lot of tools at its disposal today to help with this. So one is this new technology add-on payment model. And that's something that Congress created quite some time ago because they recognized that CMS was not able to adapt in a timely fashion to the introduction of new technologies, and clinicians were too slow in incorporating them in their practice. That was the fear in the inpatient setting. And so Congress gave CMS the ability to add new technologies to this program and to give clinicians more money in prescribing and administering these products. So there are ways in which Congress has acted in the past to give the federal government more flexibility, more discretion to act. And I think in this pandemic, we've also seen many ways in which the federal government can be flexible if it wants to. So we've seen CMS move very quickly to telehealth, telemedicine, and really increase dramatically the number of areas in which that is permitted and will be reimbursed. Whereas previously it was much less often the case that you could be reimbursed for providing services via telemedicine or telehealth. And so we can certainly use existing tools, but there is also room for Congress to act here. So in some areas, Congress has specifically allocated money as part of many of its different coronavirus related bills to encourage investment in this area, particularly diagnostic testing, particularly in the availability of these products to uninsured Americans. And I think there's every reason to believe that Congress would be motivated to address loopholes as they arise in this context. But also, I think we shouldn't let the federal government, the executive branch in particular, off the hook, because they do have some ability to do this now.
All right, we have time for one more question. This one is from Sapna Kumar, do you think that there is a political will to use Medicare as a tool for addressing drug pricing, given the lack of success with Lloyd Doggett's 2016 bill? Is this an easier sell compared to compulsory licensing, given that it's a softer tool?
So I wouldn't say that there's been a lack of success with Congressman Doggett's 2016 bill. I think over the last few years, there's really been an interesting evolution in the range of possible policy options for drug pricing that really seem to be on the table. So at the end of 2019, the House Democratic Caucus, with a couple of Republicans who also signed on, passed H.R. 3, I'm going to get the name a little bit slightly wrong. It was named after the late Congressman Elijah Cummings, the Elijah Cummings Lower Drug Costs Now Act, possibly, but it was H.R. 3. And it was a comprehensive overhaul of the ways in which Medicare would pay for drugs that allowed for Medicare negotiation of the prices of new drugs based on prices charged in other countries, which are often much lower than the prices that are charged here. It also discouraged and punished companies who raised their price faster than inflation year over year. And it did a whole range of, also had a whole range of benefits for seniors in terms of what they would pay out of pocket. And it extended many of these benefits to the commercial market as well. So Congressman Doggett's bill would have pushed more in the direction of compulsory licensing, but many of his ideas have been incorporated into what is now, I would say, the sort of mainstream position of the Democratic caucus. And I think we will see more movement on drug pricing, certainly in the next Congress.
Terrific. Well, thank you, Professor Sachs, for talking to us about reimbursement policy and responses to COVID-19. Join us next week when Professor Lisa Larimore-Ouellette will discuss innovation policy pluralism and responses to COVID-19. So I look forward to seeing you then. Thanks a lot for joining us.